Assalamu alaikum, my respected senior teachers, my dear colleagues. I am Dr. Mohammad Raisanis, Medical Officer, Aziz Bhatti Teaching Hospital, Gujarat. Today, the topic of our presentation is pediatric spine injuries, their anatomy, energy pattern, what is Shivora management. So, in this presentation, we are going to learn the basic main objectives are understand why children's spine injuries behave differently from adult. Number two, identify unique pediatric injury patterns like Shevora, pseudosubluxation, synchondrosis, fractures. Know the distribution of cervical, thoracic, and lumbar injuries in the children, and apply practice guidelines for the imaging evaluation level 1, level 2 evidence, and recall treatment principle for the common pediatric spine injuries. And in the end, recognize the Asia impairment scale and its application in children. So why our pediatric spine injuries are different? There are multiple reasons. Some of the reasons are included here, like high head to body ratio. Larger heads create greater lever force on the cervical spine during trauma. Ligamentous laxity. The joints are more elastic due to collagen 1 and more high water content in them. Ligamentous injuries are more common than fractures in the pediatric spine injuries, and immature paraspinal muscles, underdeveloped muscles provide less protection in the cervical spine. Underdeveloped actinate process, absence of small actinate, less ponylocking and more morbidity and instability. Then synchondrosis are present. The growing plate lines act as a weak points. Fractures can occur through them and can mimic the C2 fractures as well. And then the growth plate separation. Facial injuries may have excellent healing potential if managed conservatively or correctly. So epidemiology in the pediatric spine injuries. The pediatric spine injuries are very rare as compared to the adult. Just only 5% of all spinal cord injuries occur in children, and the ratio to the head to the spine injuries are 30% are head injuries and 1% are the spinal injuries in pediatrics, and 42% of the pediatric spine injuries include mainly the cervical spine. So the distribution of the cervical, thoracic and the lumbar is the cervical injuries in the pediatric spine is more like on 42%, thoracic is 31%, and lumbar spine has 27%. But the cervical spine more vulnerable to segment, especially the upper three C spine, also put C1 and C2 in children less than or equal to 9 years. Fatality rate is much higher in the pediatric in the spine injuries as compared to the adult injuries. Ligamentous injury is more common than the fractures due to the flexibility of the pediatric spine. The unique, the unique pediatric injury patterns are Shivora, abbreviated as spinal cord injury without radiological abnormality, which is also common in the pediatric spine. It includes the normal X-ray and the CT. The cord injured due to the ligamentous flexibility. MRI may show cord signal change, more common in children due to the elastic spines, and must treat clinically. Imaging can be falsely reassuring. So the second injury is atlanto-occipital dislocation, the most dangerous cervical injury in the children. Retroclival hematoma on imaging is a strong suspicion for the atlanto-occipital dislocation. CT is the imaging of the choice in these injuries. Major condyle C1 interval, often fatal without pop recognition. Then we come to the third injury, which is atlantoaxial rotator fixation, in which the C1 rotates on C2 and gets stuck. So child present with the cock-robin head tilt, 3-position CT with C1, C2 motion analysis for diagnosis is very important, because on that 3-position CT we can see the articulation or rotation of the C1 on C2. Acute, if these are acute injuries less than 4 weeks, we can go for the traction and manipulation, and if it is chronic, then halo traction. But if it still cannot correct on the or there is a neurological deficit, then we go for the surgical option. Then come to the fourth type pattern of the pediatric injury is odontoid epiphysiolysis and C2 chondrosis. Basically, the fracture through the dentocentral Synchondrosis mimics a dull type 2 odontite fracture. Age is typically mostly in the less than 7 years, because above that they will be well developed, converted into the bone. Treatment is halo immobilization, 80 to 90% success rate with conservative management. So here is an example of synchondrosis fracture radiological appearance. You can well appreciate here. Look like a fracture of C2, but in reality, it is a 23-year-old male motor vehicle crash, sagittal cervical CT bone window, and the findings are anterior angulation of odontite and several millimeter separation from the odontite to the C2 body. So diagnosis: odontite epiphysiosis, fracture through the dentro-central synchondrosis. It can mimic, it's a normal synchondrosis, but real fractures can occur through synchondrosis. So this can mimic a type 2 odontite fracture in adults, but do not confuse. Emergency management is emergency reduction and halo immobilization, and there is 80 to 90% success rate in these cases. So here comes a pseudo subluxation, a normal variant, not a fracture. We can confuse between these. You can well appreciate C2 is interiorly rotated and the C2 is posteriorly. So there is some feeling of pseudo luxation or subluxation in this, but this is not a real fracture. This is a example of pseudo subluxation. So how, when it looks like it interior displacement of C2 on C3 on lateral X-ray or CT looks alarming. Children up to the age of 10 to 14 years, most common at C2, C3, occasionally C3, C4. Basically, in that age group, this is the articulation or the flexion lever for that children. So that's why we feel that there is any subluxation, and at that point normal flexion extension centered at C2, C3 in a young children. Paraspinal spasm can exaggerate it. Repeat X-ray with head in true neutral, displacement corrects, and if not, investigate further. So if the Swiss-check line, posterior cervical line is broken, and it is above than 1.5 to 2 mm from the C2 spinous process, suspect the true fracture like in hangman. This is the line which is I'm talking about that. This is the interior marginal line, this is posterior marginal line, this is spinal laminar line, and this is posterior line. So if there is a displacement of 1.2 to 2 mm from the C2 spinous process, then we can suspect that there is a real hangman fracture, otherwise this is a pseudo subluxation. So pseudospread of the atlas, don't mistake it for a Jefferson fracture. Pseudospread, there is a greater than 2 mm total lateral mass overlap of C1 on C2 on open mouth view. 100% prevalence in the year 2 of the year, resolved by age 4 to 6 years. Disproportionate growth of the atlas over axis, which is a normal thing in the pediatrics. Maximum offset is 2 mm in 1 year, 4 mm in 2 years, 6 mm in 3 years, and it can max up to the 8 mm in. But after that, 4 years, it getting reduced, it is getting decreased, and trauma is not a contributor factor to the pseudospread. So the real Jefferson fracture is a burst fracture of C1 ring, 4-point fracture, rare, very rare in children, especially before teens, occurs in high energy trauma, and there is due to the axial loading, diving, fall on head. How to differentiate from the real or the pseudospread? The thin cut CT scans through the C1 parotid ring shows the actual fracture. So management include, in this case scenario, is immobilization plus spinous allotraction if lateral mass offset greater than 7 mm suggests stall disruption. These are different. Here's the 7 mm, greater than 7 mm is a real fracture, but it can go up to 8 mm in the pediatrics. So this is a pseudo spread of the atlas. So this is an example of Atlanto axial rotatory. You can well appreciate here the 3D segments. This atlas is rotated here. This 3D 3-cut CT scan, 3D scan is very important in these injuries to identify the real rotation on that. Next, please. So the practice guidelines when to image the Greenberg level 1 and 2 evidence-based recommendations are the level 2, the children greater than 3 years, it divided into the level 2 greater children less than 3 years. So first we come to the less than 3 years child. Do not image if all of the following are present. If the GCS greater than 13, neurologically intact, no cervical midline tenderness, no hypertension, no intoxication, not a motor vehicle accident, fall greater than 10 feet, and a non-accidental trauma. Then we come to the greater than 3 years, above 3 years child. Do not image if all of the following are present. Number one, the alert and neurological intact, no posterior midline cervical tenderness, no unexplained hypertension, non-intoxicated. If these criteria are not met, obtain X-ray high resolution cervical CT, suspected AARF, 3 position CT with C1, C2 motion analysis. So treatment principle pediatric spine injuries includes number one is the positioning. If the patient age is less than 7 years, then we have to immobilize with thoracic elevation or occipital recess. Basically in pediatrics, the head is mostly large, so the normal spine board is flat. So we cannot use for that kids. So we have to make a modification in that spine board. Like if the patient is lying less than 3-year-old child lying on a flat bed, so it automatically naturally flex the head. So because the head is flat, so we have to make a head ring like thing in which the head rest, and that in a head ring, or the other thing is thoracic elevation or use a thoracic pad here. So the we need a neutral position in that case scenario. Large head cause neck flexion when supine on flat bed. Use custom pediatric spine boards or padding under torso. The second is the C2 chondrosis fractures age less than 7 years. In this case scenario, we have to go for the close reduction, halo immobilization. 80 to 90% success rate is noted in the halo alone. Surgical fixation if persistent instability after 3 to 6 months. We will go for the follow-up slides in the end, in which when we monitor the patients of these cases, then atlanto-exorotatory fixation. If that is acute less than 4 weeks, we go for the halter traction or manipulation if no spontaneous reduction. Then if the case is greater than 4 weeks chronic case, then halter traction and tong traction is more stable, more fixed. And then if there is recurrent and irreducibility, then we go for the internal fixation plus fusion. Then we come to the ligamentous and the unstable fractures. The isolated ligamentous injuries with instability consider primary surgery. So in these case scenarios, we go for the surgeries. Otherwise, in other surgeries, we go for the traction, for the conservative management, then plan for the surgery. But in ligamentous injury, we have to go for the stability first, and we go for the surgery in that cases. So this is halo brace. It's a very strong, like it's a fixation here, here, here. So the stability of the upper quadrant of the cervical spine is very good in this traction. Very good and reliable is the cervical tongs. It's a hard fix, so you can look at there. But here in adult, we have to go for the 2 pins, but in pediatrics, as the set is so large, so we go for the 4-pin insertion. Here comes the collars, aspirin vista collar. It is a very, it's like a Philadelphia collar, but in a Philadelphia collar, we cannot remove that. We have to remove the whole part to see the under, and it is hot. But in this aspirin vista collar, it has a padding, it can be removed, it can be fixed from here and here, the height adjustment, all that things. So these are other braces we can use in the pediatrics. So this is Guilford brace. So it has a very good fixation. Look at that cases. In cases, majority of the cases of the pediatric spine injuries is can be managed with the conservative or the halo or the braces. So these are, we come to the surgical management, how we proceed if we need to go for the surgery. So these are some old techniques and the new techniques. These are some old technique. This is called a galley technique, in which these wires are connected going from the posterior arch of the atlas and then we have some graft here, and then we put a graft here and combine these wires and connect it to that. But this after some studies, this technique shows a poor fixation, and nowadays it is not really used. So then comes in 1978, Brooks and Jenkins refined the Galley technique by utilizing sublaminar wires at C1 and C2 with interlaminar wedge bone graft. The same technique, but the thing is, here we pass two wires on the laminar basis, put a graft here and tie that. In this case, we can well appreciate here. But still, this is, we can say that this is a not a proper fixation cases. But in pediatric surgeries, in pediatric spine of the patients, they are very small lateral mass and the disc, and the small tools are used in that cases. Small screws are used in that cases. So some part of the world, this technique still already be used. Another technique where there is we need the occipital cervical fusion. So in this technique, the screws are inserted here and there and occiput region, and they are connected then to the fixed head. Where there is a condylar dislocation is too much, we have to go for this technique. So then the gold standard is still the harms and the gold techniques. So in the harms and the gold techniques, we go for the two screws and two rods, and then we fix that things. But in a Magel technique, we go for the only one rod, and with the help of the one rod, we're going to fix two vertebrae. Asia impairment scale classifies severity as we discussed in the adults yesterday, but today in pediatrics, complete no motor or sensory function preserved below the injury level, including S4, S5, incomplete sensory preserved, but no motor function below the neurological level, incomplete motor preserved below the level, but 50% of the key muscles have strength, incomplete motor preserved below the level and greater than 50% key muscles have strength 3 by 5, and normal sensory and motor function. It is similar to the adult, almost similar to the adult. So this is the follow-up cervical spine clinic visit schedule, which is taken from the Greenberg. So on 7 to 10 days post-op, in the cases of pediatric spine injuries, for the post-op patients, only the wound check, remove sutures or staples if used. Then on 4 to 6 weeks, like 1 month, at 1 month, AP and lateral cervical spine X-ray and brace, no flexion extension to rule out instability or the progression of the fracture. Then we come to the 10 and 12 weeks, which is 3 months, AP and lateral cervical spine X-ray with flexion extension views out of the brace. If X-ray shows instability or progression of the fracture, patient is going to begin weaning brace. And if on 6 months, AP lateral cervical spine X-ray with flexion extension view, some surgeon release patient at this time if they are doing well at 6 months. But some surgeon continue to monitor till 1 year of the age injury. In 1 year is optional option, and AP and lateral C spine X-ray with flexion extension views release patient if they are doing well. So a clinical scenario I added in the last slide. So in which a 2-year-old boy is brought to the emergency after road traffic accident. He's crying, GCS 14 by 15. Parents report his head was not strained. On examination, he holds his neck is stiff, has no obvious weakness in the arms and the legs. Cervical tenderness at the midline. X-ray lateral spine shows an apparent interior displacement of C2 and C3. So what is the most likely diagnosis? In this case here is the pseudo subluxation of C2 on C3 as we discussed in the previous slide. A normal variant in this age group has the 2-year child. It is mostly common in a 2-year child. C3 is the pivot of the flexion extension until age 10. So must exclude true subluxation. For that we go for the imaging, repeat X-ray in a true neutral head position. If displacement corrects, this is pseudo subluxation in that neutral X-rays. Also apply Schweddick's line if C2 spinous base greater than 1.5 to 2 mm posterior to the posterior cervical line, suspect hangman fracture. So immediate management is immobilize the neck with the thoracic padding. Child large head flexes neck on the flat board. If imaging confirm no true fracture, observation physiotherapy in instability confirmed halo immobilization. So summary in the end, child spines are not a small adult spines. Ligamentous laxity, large head, growth plates make them unique. Cervical spine most commonly injured 42% and the most commonly occiput to C2 dominates in the children less than 9 years. Shivora injury without X-ray and CT abnormality, MRI essential when neurological deficit is present. AARF C1 fixed on C2 diagnosed with 3-position CT. Always remember. And the acute phase we go for the traction, in chronic phase we go for the halo, and recurrent we have to fix it. Then pseudo-subluxation C2 and C3 and pseudo-spread atlas are normal variants. Know them to avoid untreated. Overtreated. Halo immobilization is a cornerstone for C2 synchondrosis fractures in 80 to 90% success rate. Asia A to E scale quantify complete lengths and positioning matters in the children. Children less than 8 years need thoracic elevation, not a flat board to keep neck neutral. These are the references. Mostly references are taken or mostly slides are taken from the Greenberg of neurosurgery, 10th edition. And thank you so much. Any questions will be appreciated.
Spine or the lumbar spine or dorsal spine regarding kids. ये जो आपने कुछ चीज़ें हमें डिटेल में बताई हैं ना, अगर आप पीछे जाएं वो जो वायरिंग वाली टेक्निक्स हमें बता रहे थे
जी सर,
उस पर डिस्कशन करते हैं। तो बच्चों के अंदर आपको बेटे पीछे जाओ, सॉरी कैन यू गो फॉरवर्ड, पहले इसको डिस्कस कर लेते हैं फिर आगे चलते हैं।
इंडियालिस टेक्निक लगाइएगा पीछे।
हाँ, ये 3 किस्म की टेक्निक्स हैं, गेलीज, ब्रुक्स और बोमैन। गेलीज, ब्रुक्स एंड बोमैन। जो गेलीज है वो सिंगल वायर है, जो ब्रुक्स है उसमें 2 वायर्स
है। यस सर।
और जो बोमैन है BOHLMAN उसमें ट्रिपल वायरिंग होती है। अच्छा, ये आपको एक मैं वो भी बता रहा हूँ, सपोज यू पीपल आर वर्किंग समवेयर जहाँ पे आपको एक्यूट इंजरी के साथ ये पेशेंट्स आ गए और आपके साथ वो C1 C2 के स्क्रूज नहीं है या बाकी चीज़ें अवेलेबिलिटी नहीं है, तो ये जो वायर्स होते हैं ये बहुत हेल्पफुल होती है। ये वही वायर्स हैं जो के वायर्स नहीं यूज़ करते ऑर्थोपेडिक्स वाले, तो आप उन वायर्स को यूज़ करके स्टेबिलिटी अचीव कर सकते हैं। और हम अपनी ट्रेनिंग में भी समटाइम आपने ये चीज़ें यूज़ की और बहुत एक्सीलेंट रिजल्ट्स के साथ। तो स्टेबिलिटी बेसिकली अचीव करनी है ना, उसके बाद कॉलर दे दें तो बहुत अच्छा हो जाता है। तो आपके एग्ज़ाम के अंदर ये वायरिंग वाला क्वेश्चन आ सकता है
जी।
ये यंग चिल्ड्रन में तो नहीं होगा, टीन्स में होगा, जो बड़े बच्चे होते हैं यूजली जो है वो वेस्ट हम पहनाते थे वहाँ पे इस्लामाबाद के अंदर। कभी कोई पेशेंट्स होते थे फ्रैक्चर्स के तो हम उनको वेस्ट पहनाते थे। वो फौजी फाउंडेशन में आर्टिफिशियल लिम्ब सेंटर बहुत अच्छा बना हुआ है, तो वहाँ पे वो अप्लाई करते थे, उनको जैकेट्स वगैरह दे देते थे। लेकिन इंजरीज बच्चों के अंदर बहुत कम है। इसके अंदर जो सबसे ज़्यादा इंपॉर्टेंट चीज़ डिस्कस करने वाली थी दैट वाज सिवोरा, और अपने लिगामेंट्स और उन चीज़ों की बहुत अच्छी डिटेल में सारी चीज़ें बता दी थी। तो सिवोरा इज़ अ क्वेश्चन दैट कैन कम इन योर एग्जामिनेशन and regarding your own learning, these 3 techniques are very important: Gayleys, Brooks and Bowman. ये Bowman is triple wiring और Brooks is double wiring और Gayleys is single wiring। अब इसमें आपको देखिए मिसे ना सिर्फ एक वायर है जो कि इसको कनेक्ट कर रही है। नेक्स्ट में चलें, नेक्स्ट स्लाइड। इसमें 2 वायर्स हैं, देख लें आप लोग। ब्रुक्स में सब लेमिनर वायर्स हैं जो कि ऊपर से C1 से आ रही हैं और C2 के स्पाइनल प्रोसेस से ये आप करें। जो अगली आई वाज एक्सपेक्टिंग द नेक्स्ट ट्रिपल वायरिंग, उसको बोमेंस बोलते हैं, ठीक है। वो भी आप लोगों ने देखनी है। उसमें एक सिंगल वायर होती है और एक सुपीरियर और इन्फीरियर होती है और इनको आपस में कनेक्ट कर देते हैं। अगला दिखाएं। हाँ, अब मुझे और दिखाइए जो ये हार्म्स एक C1 C2 के स्क्रूज दिखा रहे थे।
जी सर,
कैन यू प्लीज गो फर्दर। जहाँ अब ये और ये जो अटलांटो ऑक्सीपिटल फिजन थी, आई मीन इट इज़ इन द एडल्ट्स। ये बच्चों के अंदर कभी भी आपने कोई ऐसा ग्रोइंग एज के अंदर आपने इम्प्लांट नहीं लगाना। ठीक सर। अगर आप इम्प्लांट लगाएंगे बच्चा तो ग्रो करेगा ना, तो आपको हार्डवेयर की फेलियर और बाकी इश्यूज आएंगे। तो ये ऑक्सीपिटल सर्वाइकल फिजन वैसे भी आजकल इतनी ज़्यादा, आई मीन आपको C1 C2 बहुत अच्छा मिल जाता है अच्छी। अगर आपको C1 नहीं मिल रहा, अगर आपके पास C1 नहीं है तो फिर आपने ऊपर से ऑक्सीपिटो करना। आप इसमें देखें जो ऑक्सीपिटल सर्वाइकल फिजन का आपको जो कंस्ट्रक्ट नजर आ रहा है,
जी सर।
एक तो ऊपर ऑक्सीपिट में,
जी
C1
सर।
में कुछ नहीं है,
ये वाला।
देखा आपने?
जी सर, एग्जैक्टली सर।
C1 में कुछ, C2
नहीं
में,
है। इसमें
C2
तो-
C3 में आ रहा है। तो अगर आपको सीटी स्कैन के अंदर C1 नहीं मिलता,
जी सर।
C1 का लेटरल मैस अच्छा नहीं है, तो फिर आप उसको बाईपास करते हैं, देन यू गो एट C2 एंड C3। अगर C1 का लेटरल मैस आपको अच्छा मिल रहा है उस पे सीटी स्कैन पे, देन यू विल गो फॉर C1 C2 फिजियन। ओके, नेक्स्ट। ओके, अब हार्म्स में और गोइल्स टेक्निक में क्या फ़र्क है?
There are two
Nowadays, if
different
you
techniques.
see in any textbook, you will, whenever there is C1 C2 fusion, वहाँ पे आपको डॉक्टर गोयल का ज़रूर कोई ना कोई आर्टिकल और उन्हीं की सारी चीज़ें मिलेंगी आपको टेक्स्ट बुक्स के अंदर। तो हार्म्स अब पीछे रह गया। उसमें गोयल्स में क्या करते हैं, C1 C2 की फ्यूजन करते हैं, लेकिन C1 C2 जॉइंट के दरमियान में बोन रखते हैं। कहाँ पे बोन रखेंगे इसके दरमियान में, बोन का पीस? या दिस इज फैसेट जॉइंट C1
Yes.
C2 का। C1 C2 के जॉइंट को एक्सपेंड करेंगे और उसके अंदर आपने स्पाइनस प्रोसेस C2 वाला तोड़ के उसके अंदर प्लेस कर दिया ऑन बोथ साइड्स। और मुझे दोबारा बताएंगे किस जगह पे आप रखेंगे? यस, गुड। इसको क्या बोलेंगे? गोइल्स।
Goels technique.
तो ये बोनी फ्यूजन भी अचीव कर रहे हैं ना। तो हार्म्स के अंदर तो सिर्फ हार्डवेयर आपने लगा दिया, हार्डवेयर यू आर प्लेसिंग वेदर इन लंबर स्पाइन एवरी एनीवेयर विदाउट अ बोनी फ्यूजन इज मेंट टू गेट ब्रोकन एंड देयर वुड बी लॉट ऑफ कॉम्प्लिकेशन। तो आप जब भी फिक्सेशन करें तो बोनी फ्यूजन जरूर अचीव करें।
बिल्कुल सर।
तो हम इसमें स्पाइन की जब फिक्सेशन करते हैं, ट्रांसपेडिकुलर सर्कुलर फिक्सेशन, उसमें भी तो ऐसा करते हैं ना।
जी
तो
सर।
डिकम्प्रेशन करने के बाद जो बोन के पीसेस होते हैं उनको हम क्लियर करने के बाद वी प्लेस अराउंड अराउंड द बोन और बाकी चीज़ों जो सक्यूज के दरमियान में भी। तो कल जो हमने सी में जो कॉर्पेक्टमी करके हमने जो इम्प्लांट लगाया था,
जी
उसके
सर,
अंदर भी हमने
उसमें भी
बोन
डाल-
के पीसेस रखे थे। तो हार्म्स के अंदर देखें सिर्फ फिक्सेशन आप अचीव कर रहे हैं, लेकिन आपने मेक श्योर करना है कि जब भी आप C1 C2 की फ्यूजन करें, आपने इनके फैसेट्स के दरमियान में बोन का पीस रखना है। और ये गोल्स टेक्निक और ज़्यादा इसकी सक्सेस और बाकी चीज़ें ज़्यादा अच्छी हैं। लेकिन अगेन ये अडल्ट की प्रोसीजर है, या कोई ऐसा बच्चा जो कि आई मीन ही इज़ 18 19 20 मे बी यू कैन गो फॉर दैट। लेकिन यंग बच्चों के अंदर जो छोटे बच्चे हैं उनके अंदर हमेशा सिवोरा हम वो करें, और यूजली वो बहुत अच्छे रिजल्ट्स होते हैं। बोन के फ्रैक्चर्स कम है छोटे बच्चों के अंदर। जब हम पीड्स की बात करते हैं ना, तो ये बहुत बड़ा ग्रुप है। एक तो छोटे बच्चे हैं, तो यूजली वी आर टॉकिंग अबाउट जो आपने ये सर्जिकल और ट्रैक्शन और सारी चीज़ें बताई हैं, तो दिस इज़ यूजली डन इन किड्स हु आर अबव 15। छोटे बच्चे तो वो बेचारे उसको पहनेंगे भी नहीं, जो जैकेट और स्पेशली ये चीज़ें आपने लगाई हैं। उनको इमोबिलाइज करें और अल्लाह ताला ने उनकी जो लिगामेंट्स और बाकी चीज़ों में स्ट्रेंथ रखी होती है, वो यूजली हमने देखा कि बोनी फ्रैक्चर्स कम है बच्चों के अंदर।
Yes. बेसिकली जो है ना, जो लिगामेंट्स हैं, ये जितने भी हमारे लिगामेंट्स हैं बच्चों में, C1 कोलेजन 1 होती है, टाइप 1, विच इज़ वेरी इलास्टिक एंड विच इज़ वेरी हैवीली वाटर कॉन्टेंट। ठीक है, बट जब उसको इंजरी होती है, तो जब लिगामेंट दोबारा रिपेयर फेज में जाता है ना, दैट इज़ कोलेजन 3। कोलेजन 3 से वो कोलेजन 1 में जाता है, बट दैट क्रिएट्स अ स्कार टिश्यू वेरी वीक स्ट्रेंथ विच इज़ अराउंड 70 to 75%। तो उस वीक स्ट्रेंथ के साथ वो सारी लाइफ जो है वो उसको जाएगा, तो अनस्टेबिलिटी के चांसेस बहुत ज़्यादा हैं। तो फिर इन केस ऑफ द लिगामेंटस इंजरीज वी गो फॉर द फिक्सेशन टू स्टेबिलिटी, क्योंकि आप फर्दर देखेंगे C2 के अंदर जो है वो आपका टाल लिगामेंट है। ठीक है, उसने सारी लाइफ उसको स्टेबिलिटी देना है। और नंबर 2 जो मैंने बताया C2 सेनकॉन्ड्रोसिस, आप कहेंगे कि सर वो भी तो एक गैप है ना, अगर द फ्रैक्चर है वहाँ तो 80 to 90% सक्सेस रेट मिल रहा है विद हेलोट्रेशन बाय दैट। बेसिकली दैट इज हाइलिन हाइलिन कार्टिलेज, दैट इज अ वेरी गुड स्ट्रेंथ। और वो जो हील होता है, जब वो बढ़ता है, उसकी अराउंड बोन जितनी ही स्ट्रेंथ आ जाती है, तो वो दैट इज स्टेबल और कैन बी स्टेबल विद द ब्रेस। बट इन द लिगामेंटस इंजरी वी हैव टू गो फॉर द स्टेबिलिटी और द फिक्सेशन। तो हमें उसे फिक्स करना है, क्योंकि जब वो हील करेगा तो वो स्ट्रेंथ अपनी 70 to 75% है। सर आई एम करेक्ट?